I'm Dr. Shivayan and I'm going to be presenting on prophylactic buckling in retinal capillary hemangioblastoma, early intervention to prevent progression in one-eyed patients. So we had a 29-year-old female presenting with diminution of vision in right eye for the past 3 years. She had history of trauma in the right eye by her child's hand in 2020, followed by gradual painless diminution of vision for 6 months, followed by sudden loss of vision. She presented on 3rd October 2024 with vision of no PL in the right eye. She had history of laser in both eyes with no surgical intervention done outside and with no documentation available. She had no history of any systemic disorders, no history of ocular surgeries, no history of using any high-power glasses, flashes, and floaters, no relevant family history. Coming to examination, we noted that she had no PLI in her right eye. Her left eye was within normal limit with refraction improving to 6/9. She had total hyphema in her right eye, and on ultrasound, B-scan showed a small-sized globe with disorganized intraocular contents with moderate homogeneous spikes in vitreous cavity. In left eye, we noted a superiotemporal active angioma which was partly lasered with fibrous traction. The FR was dull with a grade 0 ERM and laser scars were present inferiorly with a laser regress angioma. So coming to the Optos clinical picture, here the first thing that we see is a superiotemporal protuberant nodule, followed by a feeding arteriole and a draining vein. Then we can see a few laser spots in the retina, and then inferiorly a few red nodules, and in the fovea we can see a grade 0 ERM. Based on this, our differentials were retinal hemangioblastoma, vasoproliferative tumor, and retinal artery macroaneurysm, out of which the most 4 points were for retinal hemangioblastoma because of age of onset, the presence of feeding and draining vessels, and the peripheral site of the lesion. So based on this, when we went ahead with an fundus fluorescein angiography, in the arterial phase, we can see the feeding arterioles feeding the tumor. Then in the early venous phase, we can see the draining vein. And then in the late venous phase, we can see a leak over the lesion, followed by laser scarring, staining of the laser scars. And inferiorly, we can see multiple small hyperfluorescent masses, 3 inferiorly and 1 superiorly. Then we elicited additional history. She had no history of any auditory symptoms, no history of excessive sweating, panic attacks, no relevant family history, no history of headache, abdominal pain, or blood in urine. Coming to systemic evaluation, the MRI was within normal limit, the audiometry was within normal limit. The ultrasound abdomen revealed multiple cysts noted in the head, body, and the tail of the pancreas, averaging 12 into 14 millimeters. And kidney showed a simple cyst at the upper pole, which was 44 into 34 millimeters. So the provisional diagnosis of retinal hemangioblastoma VHL was made based on the Danish criteria and international criteria. It requires, as she had negative family history, it required 2 VHL-related manifestations, out of which she had retinal hemangioblastoma and multiple pancreatic cysts. So previous studies have shown that laser treatment can be considered as the primary form of management for the management of retinal hemangioblastoma. So we decided to do direct laser over the small hemangioblastomas and feeding arteriole laser for the large hemangioblastoma in the initial settings, followed by laser spots over the hemangioblastoma, and regression was monitored. On 1 month follow-up, regressing hemangioblastoma with traction was noted. In this Optos CP, we can see the lesion with peripheral tractional retinal detachment and traction. So in view of this, we diagnosed the patient as left eye multiple laser retinal angiomas with superiotemporal regressing angioma with traction. And we decided to go for a buckling procedure which has been done previously in cases of large hemangioblastomas along with plaque brachy. But in our case, as the tumor was regressing, we decided to go for left eye buckling with a single freeze-thaw cryotherapy of hemangioblastoma under LA. On post-op medication, she was started on topical steroids and a short course of oral steroids, and topical antibiotics and cycloplegics were given. On post-op day 1, we can see the cryo mark with subretinal fluid around the cryo mark, which is an expected finding. However, on post-op day 2, we saw that there was an increase in the extent of the subretinal fluid, with the cryo mark can be still visible. So post-op day 2, her vision had dropped to 636. This was a one-eyed patient, so it was a bit serious. And she had anterior sanguine findings which were within normal limit, and the SRF noted in the superiotemporal quadrant with cryoburns. But on 1 week post-op, because of the steroids and the topical steroids, her vision came back to within normal limit what she had before. The resorption of subretinal fluid was noted, and repeat laser of hemangioblastomas was done after 1 month. This was a 1 month follow-up in which we see that the mass is regressing, the traction was resolved, and grade 2 ERM was seen over the foveal region. So retinal hemangioblastomas present in the second decade. There are multiple tumors in cases of VHL, and the cause of loss of vision can be multiple, ranging from exudation, traction, complications, and secondary manifestations. In average range of presentation of retinal hemangioblastoma is 25. So it is the earliest manifestation of VHL disease which is seen in individuals. So the take-home message is that understanding retinal angioma is crucial for the timely diagnosis and management and to prevent vision loss. The clinical presentation can vary widely, but thorough evaluation should be done. And syndromes like VHL should be recognized, and screening of other eye and family members is a part of the timely management of the condition, and that can prevent vision loss in such patients. Thank you. Thank you.
Very nice, very unique presentation, Shivayan. Wondering whether any role of anti-VEGFs?
Sir, anti-VEGFs have they have been noticed to have a role, but there's a newer agents like bezlotifan and all, which have been noted. They are HIF inhibitors, which have been noted to play a role in the management in VHL patients, especially.
What buckle you used, and you used a circumferential or radial buckle?
Sir, it was a segmental buckle, circumferential buckle. So
what is the size?
Sir, it was 276 asymmetrical buckle with posterior extent more than anterior.
276.
277. Sir.
Okay.
How do you do laser in these?
Sir, in cases of small hemangioblastomas, they are lasered directly. But in cases of large hemangioblastomas, we have to laser first the feeding arteriole, followed by laser over the hemangioblastoma. Then we can laser the draining veins. And in the meantime, we also have to make sure that the laser we are giving is of longer duration and it is of lesser power.
I wanted to know the feeding. In first sitting, you should do laser around the feeding vessel.
Yes.
And
around the
I would do laser, heavy laser around the feeding vessel.
Yes.
Leave it for 1 week for it to shrink.
Yes, sir.
Leave it for 1 week. And then do on the main mass.
Yes.
And use very large
Yes.
size
Large
and heavy
size
pumps.
and large duration.
In my days when we had xenon arc photocoagulator,
Yeah.
so we used to do xenon arc, which were more effective than laser, because xenon arc is much bigger spots.
Bigger spot size. And delivered to the direct this thing, xenon arc. I remember my chief, Dr. Badrinath, used to do that regularly, sir, that time, xenon arc. And because the cryo is probably one of the best for hemangiomas.
Cryo is effective.
Triple freeze thaw technique, you can use that because you'll be able to cover the entire lesion, because it's quite a big laser will not be able to cover.
So one thing that we noted in the case was that the buccal indent was not as posteriorly as we would have liked in this patient. As in the optocp, we could not see the posterior indent over the lesion, but still the traction had resolved, so the patient was asymptomatic at that time.
Even the transpupillary thermotherapy is good, TTT.
Yes.
We do that for hemangiomas that time. Now it's not available. Not that it's not available. We are not using that much. So, any questions?
Thank you.